All right, so today we start our section on congenital heart disease. And so in many ways, this is probably the most important lecture because it gives you kind of an overview of the things that we're going to be talking about. So here we'll talk about the plain film approach to congenital heart disease. And in terms of the plain film approach, this is an order of how you can go through things. In most cases, looking at the skeletal system is not going to help you, but once in a while you will make a finding and then you might be able to hit a home run from that. A sinus is something that's usually obvious, but we'll talk a little bit about that. The most important thing is the status of the pulmonary circulation. So that is where you always want your discussion to begin if we're talking about congenital heart disease. You start with the status of the pulmonary circulation. And then an important piece of information that you need to know is the patient cyanotic or not cyanotic? And then we'll talk about the position of the aorta and the pulmonary artery, as that is also important and can help us. Specific chamber enlargement, we'll talk about the heart size and then specific chamber enlargement. So the arrow is pointing to a finding. What is the finding?
Rib notching?
Rib notching. So this rib notching, probably the most famous finding when we're talking about heart disease. So rib notching is associated with coarctation of the aorta, right. The problem with rib notching is if you look for it, you can almost imagine it on every film if you start looking for it. So it's a very subtle finding often. Sometimes it can be normal, it can be hard to convince yourself whether it's real or not, okay? But if you think you see rib notching, the next place to look really is the mediastinum and the configuration of the aorta. Because if you have coarctation, really, you might see this, especially out of boarding, you might see this figure of 3 configuration of the aorta. And that's where the coarct is over here. And so here's the correlate on this MR study. So if you think you see rib notching, look very carefully at the contours. Here's the rib notching. Look very carefully at the contours of the descending aorta and look for that figure of 3 something. Now in this particular case, I'm asking you to look at the ribs, and when you look at the ribs, what do you notice? By the way, anybody can answer, even if you're out in virtual land, all right? So we'll open this up to the whole group as I ask questions going along. Anything about the ribs? How about we count the ribs? All right, so what's the significance of that? Yes, right. So too few ribs or too many ribs can be associated with Down syndrome. And what congenital cardiac malformation is Down syndrome associated with? ASD and VSD, that combination. So those are called what? Endocardial cushion defects, right. So abnormalities in terms of the number of ribs can be associated with endocardial cushion defects in somebody with Down syndrome. Right? So here we have these radial ray anomalies associated with congenital heart disease. What syndrome is that? Anybody out there? Okay, so this is Holt-Oram syndrome, radial ray defects, also associated with septal defects. So especially atrial septal defects. So radial ray defects can be associated with cardiac septal defects. Okay. This person has pectus. So what's the important thing as far as the heart goes? If we see pectus, what can that be associated with? Marfan. So what cardiac abnormalities can Marfans be associated with? Aortic regurgitation from what? Yeah, from annular aortic ectasia, dilatation of the aortic root. Okay. Anything else in the heart that you get with Marfans?
Mitral valve.
Yeah, mitral valve prolapse, right. That can also be associated with Marfans, right? So pectus can be associated there. So this particular case, there's annular aortic ectasia, some aortic regurgitation, right? So we can see that in patients with Marfans, right? And also we mentioned mitral valve prolapse can also be associated with morphine. So rib notching, coarctation of the aorta, too many ribs, too few ribs can be associated with Down syndrome or endocardial cushion defects, atrioventricular septal defects. Pectus can be associated with Marfan's, annular aortic ectasia, aortic regurg, mitral valve prolapse. Bulging sternum, so Pectus Caranana, can also be associated with large left to right shunts. So that's another problem that we might see. Radial ray anomalies, Focal-Aran syndrome, especially septic defects. Limb and vertebral anomalies, Bacterial syndrome associated with DSD. What do those letters stand for? Vertebral, anal, cardiac, T fistula, renal, and L is limb, right. So that's what those letters stand for. Osteogenesis imperfecta can be associated with aortic regurg and polydactyly. Prevalent syndrome associated with common atria. Now, what about situs? Usually situs problems are kind of obvious when you look at the x-ray that there's something, terribly wrong that we have to figure out. But when we use the word situs, well, what does that mean? What does situs mean, that term? What is it referring to? So situs is the configuration of organs within the body, right? So there's a certain configuration of organs within the chest are associated with a configuration of organs within the abdomen. So there are three types of situs that we like to talk about when we're talking about congenital heart disease. There's the normal is called situs solitus. So when you have situs solitus in the abdomen, the organ that's on the right side is the liver, right? And then when we talk about the lungs, we have the trilobe lung and the bilobe lung. So the trilobe lung and situs solitus is on the right, and the bilobe lung is on the left, and of course the spleen is on the left also. But when we're talking about situs as relates to the heart, and we'll get into this in a later lecture in more detail, when you're talking about the situs of the heart, what is it that you're referring to if we're talking about the situs of the heart? Because remember, if you have situs solitus, your liver's on the right side, and usually your trilobe lung is on the right side. But what part of the heart is on the right side if you're talking about situs solitus? So situs, when you're talking about the heart, refers to what?
Right ventricle?
No.
Left ventricle?
No. No.
The valves.
No.
Side of venous return of blood.
It's kind of... No. What's left? I think you picked off everything. The atria. The atria. The atria. When you're talking about situs of the heart, you're referring to the atria. So why is that? It's because the right atrium, right, usually receives the inferior vena cava. It comes from the liver. So the right atrium tends to be on the same side as the liver. So the atria differentiate very early in embryology. The ventricles take their positions later. So when we say situs solitus, we mean the atria. We're talking about the situs of the atria. So with situs solitus, the right atria is on the right side. It's on the same side of the body as the liver and the trilobe lung. Okay, and the left atrium is on the left side, same side, or to the left of the right atrium, really. And it's on the same side of the body, usually, as the spleen and the bilobe lung. The ventricles can be on either side, and we'll get into that in more detail later on. But when you're talking about situs for the heart, you're talking about the configuration of the atria, okay? And that's because it's very early in embryology when the pulmonary veins develop their connections to the left atrium and the inferior vena cava develops its connection to the right atrium, all right? So that's situs solitus. Now the mirror image of that is called situs inversus, right? So there's some patients that can be the mirror image, and that's usually easy to spot because, you notice the cardiac apex is on the right side and the stomach bubble is on the right and the liver is on the left. So the organs are the mirror image of normal. Now there is another configuration where things get very confusing. Hard to decide where the liver is on, right? It's kind of in the middle, what's going on with the stomach, and then the cardiac apex is over here. So things are hard to figure out. What is this called? This is situs ambiguous, right? And the two syndromes that situs ambiguous is associated with are what? Asplenia and polysplenia. So which one is more likely to be seen in an adult patient? Polysplenia. Yeah, asplenia is associated with severe congenital cardiac malformation, so that you're going to see in an infant. But polysplenia, you might pick up in an adult. So if you have situs ambiguous in an adult, think about polysplenia. Right? So that's our brief discussion of situs, and we're going to get into much more painful detail later on. Now, when we're talking about congenital heart disease, the important radiographic findings, you always start your discussion of congenital heart disease with the pulmonary vascularity. Only an amateur starts with the heart when you're looking at a plain film. All right? So when you're looking at the plain film for congenital cardiac disease, you always start with the pulmonary vascularity. Right? So you want to know, is it increased or decreased? Then you could look at the heart, cardiomegaly versus near normal heart size. That will help order your differential diagnosis. The important clinical data you want to know, is the patient cyanotic or acyanotic? That's an important question that you need to know the answer to in terms of discussing your differential diagnosis for the plain film appearance. And then the presence or absence of symptoms, that also might be able to help you in terms of ordering your differential diagnosis. But the most important things are going to be the status of the pulmonary vascularity, and is the patient cyanotic or not cyanotic. Those are usually the pieces of information that we start our differential diagnosis when we talk about the heart. So regarding the radiographic appearance of pulmonary circulation in congenital heart disease, what are the three abnormal states of pulmonary vascularity that we can assess on a chest radiograph? What are those, for congenital heart disease, what are those three abnormal states of vascularity? Right, so there's increased pulmonary vascularity. There's, right, so there's decreased pulmonary vascularity, and what's the third one? It says abnormal. The question says abnormal. Pulmonary venous hypertension, right, so pulmonary venous hypertension is the third state, okay? And if anybody knows a nice trick to keep this thing off of there, let me know. Anyway, so abnormal states, increased pulmonary vascularity, over-circulation, decreased pulmonary vascularity. Those patients, by the way, are always cyanotic if they have decreased pulmonary vascularity. And then pulmonary venous hypertension. Rule of thumb, if pulmonary vascularity appears normal, but the patient is cyanotic, consider that equivalent to decreased vascularity. And this is the plain film approach. We're talking about the plain film approach here. Okay? All right, so we start with this case. So again, we're talking about congenital heart disease. We always start with the pulmonary vascularity. So when we look at this radiograph, what do we think of the pulmonary vascularity? Increased, right. So here it looks like we have increased pulmonary vascularity, big pulmonary arteries, stuff is going all the way out there through the periphery. What question do you ask?
Cyanosis or not?
Yes, the question you want to ask is the patient cyanotic or not cyanotic? Because that's going to determine what differential you use or what you do next. So here there's increased pulmonary vascularity, over circulation due to ventricular VSD. This patient was not cyanotic. All right. So here, what do you think of the pulmonary vascularity? Decreased. What question do you ask? Do you have to ask that question? No, why not? All patients with decreased pulmonary vascularity will be cyanotic. Right? So if there's decreased vascularity, they're going to be cyanotic patients. And we'll talk about the approach of how we approach the film on that, as we go along. So patients with decreased pulmonary vascularity, notice the small pulmonary arteries, decreased blood flow there within the lungs, they will always be cyanotic. Okay? Here, what do we think of the pulmonary vascularity? Yeah, so here it looks like we have all of these interstitial lines, and we also have pleural effusions, right? So this looks like interstitial edema. Now, if you're not in a congenital cardiac lecture, you'd look at that and you'd say meconium aspiration, right? If you're dealing with you're dealing with real life. But here we're talking about cardiac disease. So with all these interstitial lines and the pleural effusions here, we're talking about CHF or interstitial edema. Right, is the state of pulmonary vascularity that's illustrated there. Okay. Now, when we have increased pulmonary vascularity and the patient is acyanotic, so acyanotic with increased pulmonary vascularity, what are the three most common lesions? So first of all, You're in the category of what? So if we're talking about increased vascularity and acyanosis, you're in the category of left to right shunts. The three most common left to right shunts are PDA, right. So those are your most common left to right shunts. So that's the category of left to right shunts. That gives you increased pulmonary vascularity and no cyanosis. So atrial septal defect, ventricular septal defect, making ductus arteriosus. So all of these give you increased pulmonary vascularity. These are the most common left to right shunts that you'll come across. Okay? Now, you might have symptoms of congestion or CH or CHF if there's a very large left to right shunt. The degree of cardiomegaly is usually proportional to the increase in pulmonary vascularity due to volume overload, so the heart can get bigger if your shunt is larger. This is important as far as the plain film goes. As far as the plain film goes, you need at least a 2-to-1 shunt, meaning the pulmonary blood flow has to be twice the systemic blood flow before you actually can see that and perceive that on the chest radiograph. That's why you can have patients who go to echo and they find atrial septal defects or ventricular septal defects, and the chest radiograph looks completely normal, right? You need a relatively large shunt, 2-to-1, before we can actually see the changes on the chest radiograph. So chest radiograph is sensitive compared to echocardiography for this. Now, when we're dealing with these left to right shunts, another thing is what chambers are going to be enlarged. So, and these also you might be able to discern on your chest radiograph in terms of enlargement of these chambers. So if we have an atrial septal defect, what chambers are enlarged? Yes, so right atrium and right ventricle. So an atrial septal defect gives you isolated right heart enlargement, right atrium and right ventricle. Partial anomalous pulmonary venous connection, we haven't talked about that yet, but what chambers would be enlarged with a partial anomalous pulmonary venous connection? Is that it? So well, I'll do you a favor. You can store partial anomalous pulmonary venous connection on the same neuron as atrial septal defect, because they look the same as far as the chest radiograph. Both of those will give you right-sided cardiac enlargement, right atrium and right ventricle. Okay? Ventricular septal defect, what chambers are enlarged?
Left ventricle, right ventricle, left atrium.
Not, so biventricular enlargement, both ventricles and the left atrium. Okay? So those are the chambers that will be enlarged with a ventricular septal defect. Now, when we're dealing with endocardial cushion defects, if we have a mild endocardial cushion defect, that acts like an atrial septal defect. If you have a complete endocardial cushion defect, that acts like a large ventricular septal defect, all right? So that you can handle that also. PDA, what chambers are enlarged with a PDA?
Left atrium and ventricle.
Yes, so PDA gives you left-sided enlargement, left atrium and left ventricle. So a nice way to think of this is atrial septal defect gives you isolated right heart enlargement, PDA gives you left-sided enlargement, and VSD gives you biventricular and left atrial enlargement. The important point is the left atrium is something that you might be able to figure out on a chest radiograph. If the left atrium is not enlarged and you're in the category of left to right shunts, what should you be thinking about? ASD, right. So ASD is the left to right shunt that gives you right-sided enlargement, but you don't get left atrial enlargement with an atrial septal defect, okay? All right, so congenital heart disease, we start with the pulmonary vascularity. What do we think of the pulmonary blood flow here? Increased. What question do you ask?
Cyanosis.
Patient is not cyanotic. What category are we in? Left shunts. We know what our biggies are, and I have given you a lateral chest radiograph. So what can you tell me from the lateral chest radiograph?
Right ventricular enlargement.
It looks like there's right heart enlargement, right? There's encroachment on the retrocoronal steep space. And what about the status of the left atrium? Is it enlarged? Is the esophagus deviated posteriorly?
No.
No. All right. So what are we thinking about here?
ASD states.
Okay, so ASD. So you have right-sided enlargement, the left atrium is not enlarged, you're in left to right shunts, the category of left to right shunts. So that's an atrial septal defect. Okay? In this particular case, what do we think of the pulmonary vascularity? It's increased, no cyanosis, we're in the left to right shunts. What can you say from the lateral chest radiograph? The left atrium is enlarged, right. So it's pushing on the esophagus there. So what shunts might you be thinking about here? Yeah, so here you might consider VSD and PDA. Although usually with a PDA, the aorta is larger, but this turns out to be a median VSD. So there's enlargement of both ventricles, but there is enlargement of the left atrium. So this is not going to be an atrial septal defect. Once you see the left atrium enlargement, then you're not going to consider ASD. What do we think of the pulmonary vascularity here? Increase. What question do you ask? Cyanosis or not cyanosis, right? Well, here I'm going to tell you the patient is cyanotic. So what category are we in now? Not right to left shunts. You're in the category of admixture lesions or bidirectional shunts. Okay? So when you're in the category, so it's the bidirectional, what happens with the bidirectional shunts is the left to right shunting gives you increased pulmonary vascularity, but the right to left shunting is what's going to give you cyanosis. Another thing you know is that there probably is not pulmonary stenosis, because if you had pulmonary stenosis, that would give you decreased pulmonary blood flow. So you have an admixture lesion here that's giving you cyanosis, but there's not going to be pulmonary stenosis because you have increased pulmonary vascularity. Okay? Now there's a cute little mnemonic that you might use for the differential diagnosis of the admixture lesions. Do we know what that is? The T lesions, right? Have you heard of that? The T lesions? So what are the T lesions?
Tetralogy.
No,
Truncus,
because tetralogy gives you what? You've heard this before. Tetralogy gives you decreased pulmonary vascularity because they have right to left shunts. All right, so people think T lesions, tetralogy. No, do not do that. Okay, bad, very bad. The three big T lesions, though, that you do need to know quite well are, you went through them, transposition and total anomalous pulmonary venous return. Right. So we've talked about the bidirectional shunts, the admixture lesions, the three big T lesions you mentioned. Those are the three that you do want to know something about. Okay. So it's the mix of the circulations that gives you this combination of increased pulmonary blood flow and cyanosis. There's no pulmonic stenosis, that's why you had increased pulmonary blood flow. All right. Not tetralogy. You don't want to say tetralogy. So transposition, truncus, total anomalous pulmonary venous connection. Now there are some others, tricuspid atresia with a large VSD and no pulmonic stenosis, single ventricle, hypoplastic left heart, double outward right ventricle, common atrium. Those are some more unusual ones. So here's a nice mnemonic, 5 T's in CAD. Transposition, truncus, total anomalous pulmonary venous return, tricuspid atresia without pulmonic stenosis, single ventricle, tingle ventricle if you want, right? Common atrium, hypoplastic left heart, which is a form of aortic atresia, double outward right ventricle. So that you can memorize. But the point is not tetralogy of form. So we don't want to think about that. All right. So the three big ones you want to know, detransposition, truncus, total anomalous pulmonary venous return. So the physiology and the clinical presentation will depend on the size and locations of the shunts. These patients will have ASDs, VSDs, PDAs, and the absence of pulmonic stenosis. It's the absence of pulmonic stenosis that gives you the increased pulmonary blood flow. If you have pulmonic stenosis, then the physiology might be similar to tetralogy of flow with decreased pulmonary blood flow. Okay? So getting back to our case, patient is cyanotic, has increased pulmonary blood flow. We're in the category of admixture lesions. Which one do you favor and why? Why? Yes, so this has the egg on a string appearance on the plain film. So how do you characterize the egg on a string? What's the egg? What's the string? heart is the egg, right? So there's some cardiac enlargement. What's the string?
Great vessels.
The mediastinum. Notice the mediastinum is narrowed, right? So it's the narrow mediastinum that is the string, the egg is the heart. So why is the mediastinum narrowed in patients with transposition? Well, there are two reasons. One, when we see those kids with the big mediastinums that first-year residents keep talking about big masses, it turns out that the mediastinum looks big because of the thymus, right. So whenever there's stress, there's thymic atrophy, so that will contribute to the narrow mediastinum. The second thing is with transposition, the configuration of the vessels, rather than being side by side, they may overlap more, the aorta and the pulmonary artery, which also contributes to the narrowing of the mediastinum. Okay. So the egg on a string appearance, okay, is associated with transposition. If I use the word transposition, when you use the word transposition, what is the definition of transposition? What does that word mean?
Lack of discordance between the great vessels and the ventricles.
Yes. So transposition means ventriculo-arterial discordance. Put those two together. Transposition is ventriculo-arterial discordance. Whether it's LD, corrected, not whatever. When you use the word transposition, you're saying there's ventricular-arterial discordance. That means a morphologic right ventricle is connected to the aorta. And a morphologic left ventricle is connected to the pulmonary artery. That is the definition of the term transposition. Start there and don't confuse yourself with everything else yet, but understand what the word means. Okay? So, when we have transposition then, detransposition is usually the one that we talk about with cyanosis and increased pulmonary blood flow. And they can have these, to be compatible with life, there have to be these other shunts that allow communications between the right and the left circulation. And they can be ASDs, PDAs, or DSDs. Okay? So it's the detransposition with intermediate shunts that give you this appearance of the egg on a string. So moderate cardiomegaly, increased pulmonary blood flow, narrow mediastinum, the egg on a string appearance, and these patients will be cyanotic. All right, so another patient with increased pulmonary blood flow, and I'm telling you that the patient is cyanotic. What do we favor here and why? So why do we favor that?
The snowman sign.
So the snowman appearance, right? So the snowman appearance is associated with total anomalous pulmonary venous return type what?
Type 1.
So I see 1, 2, 5. There is no 5.
A number between 1 and 9.
Okay, some number between what? Type 1, supracardiac total anomalous pulmonary venous return. So total anomalous pulmonary venous return type 1, supracardiac, is associated with the snowman configuration, right, on the plain film. So why do we get that? Well, with total anomalous pulmonary venous return, the pulmonary veins, instead of returning to the left atrium, they form a common pulmonary vein, and that can return here to the left brachiocephalic vein, which then goes to the superior vena cava to the right atrium. So it's enlargement of these vessels here in the superior mediastinum that give you the head of the snowman. So total anomalous pulmonary venous return type 1 gives you that snowman appearance on the plain film. So your common pulmonary vein drains to the left brachiocephalic vein to the superior vena cava, and that's what gives you that snowman appearance for total anomalous pulmonary venous return. So another patient here, increased pulmonary blood flow, cyanotic, and here I'm giving you an MR. What does this patient have?
Truncus.
Yeah, so this is truncus arteriosus. So what happens with truncus arteriosus is that there is a common vessel here that sits on top of a ventricular septal defect. So that common vessel, the truncus, receives blood from both ventricles. And then from that vessel, you will have then the aorta and the pulmonary artery will come off that vessel. So that's what we see with truncus arteriosus. So these patients will also have increased pulmonary blood flow, and they will be cyanotic. So it results from failure of division of the primitive truncus into the aorta and the pulmonary artery. So the truncus sits on top of a ventricular septal defect, so the admixture, all of the blood kind of mixes here in the truncus and then goes off into the aorta and the pulmonary artery. Okay? So Here, the pulmonary blood flow is decreased. I'm telling you, the patient is cyanotic. What do you think this patient has?
Tricuspid Atresia.
It's possible, but I wouldn't start there. Why tetralogy of Fallot?
The right ventricle.
So you've got this boot-shaped heart over here, all right, with the elevated apex with decreased pulmonary blood flow, right? So the boot-shaped heart with decreased blood flow, we know that that's going to be tetralogy of Fallot. Is there a differential diagnosis? Can it be anything else except tetralogy of Fallot? Well, it can, but, of course, less likely, but we'll talk about that too. Now, there's another finding on the plain film, a bonus finding that is also associated with tetralogy of Fallot. What's the bonus finding?
The arch is on the right.
Yeah, there's a right aortic arch. So tetralogy of Fallot is also associated with right aortic arch. Okay, so that finding can also be associated with tetralogy of Fallot. All right. Now, this patient, pulmonary blood flow is decreased. Patient is cyanotic. What's different about this, though, as opposed to the last case that I showed you?
Cardiomegaly.
Yeah, here there's cardiomegaly, as opposed to the case of tetralogy of Fallot. There's near normal heart size. Here there's cardiomegaly, and especially what chamber appears enlarged?
Right atrium.
Yeah, the right atrium appears enlarged here, okay? So here, the typical lesion that's going to give you this appearance of a big heart, especially with an enlarged right atrium, decreased pulmonary vascularity, and cyanosis, what is the lesion to think about here? Epstein's. So here, the lesion to think about is Epstein's anomaly. All right, that's going to give you that configuration of the heart. So when we're in this category of decreased pulmonary blood flow, of course, they're going to be cyanotic. There's obstruction of blood flow through the pulmonary circulation, and that's what's, of course, that's why they have decreased pulmonary blood flow. You can have patients with no cardiomegaly, and there we're talking about tetralogy of Fallot or tetralogy of Fallot-like lesions. Or you can have patients with cardiomegaly, especially with that enlarged right atrium, and here we're talking about Epstein's-like lesions like Epstein's. So the tetralogy of Fallot-like lesions, what do these have in common? Usually it's a ventricular septal defect with obstruction to the pulmonary artery, infundibular stenosis. So it's because of this obstruction to the pulmonary artery, to the pulmonary blood flow at the infundibulum, and because of the ventricular septal defect, they develop then right to left shunting, so they will have decreased pulmonary blood flow and cyanosis. So that's what these lesions have in common. That's typical of tetralogy and what tetralogy-like lesions might have in common. Right. As opposed to Epstein's, what happens here with Epstein's is that because of the malformation of the tricuspid valve, there's a physiologic obstruction of blood flow through the right side. There is an atrial septal defect, but it can be rather small and restricted. And so it's the shunting across the atrial septum that results in the right to left shunting and the cyanosis. But as a result of this obstruction, the right chambers enlarge, especially the right atrium. So they will have then the cardiac enlargement with right atrial enlargement with Epstein's. Okay? So decreased vascularity, no cardiomegaly. We're talking about a non-restrictive ventricular septal defect, usually a good-sized ventricular septal defect that results in equalization of pressures of the ventricles of the right and left ventricle. That's what we see with tetralogy of Fallot. Well, what are other things that can do it? Any admixture lesion with pulmonic stenosis, especially if they have a ventricular septal defect, will have physiology similar to tetralogy of Fallot. So that physiology is obstruction of pulmonary blood flow with a non-restrictive ventricular septal defect. Right? That allows for that forces kind of that right to left shunting. Then there's some other things in that category also, tricuspid atresia with a large ASD and pulmonic stenosis, and pulmonary atresia with intact ventricular septum type 1. But tetralogy is your classic, the upturned apex, right aortic arch. Of course, you want to start with the decreased pulmonary blood flow. Okay. All of these look like tetralogy, and just to show you not everything that looks like tetralogy is tetralogy. This is single ventricle with pulmonic stenosis. This is transposition over here with pulmonic stenosis, double outlet right ventricle with pulmonic stenosis. So any of these admixture lesions with pulmonic stenosis, especially if they have a ventricular septal defect, will have physiology similar to tetralogy, and they will resemble tetralogy on the chest radiograph. Okay. Now, on the other hand, if we have right to left shunting through an atrial-septal defect or pain foramen ovale with some obstruction of blood flow through the right heart, like we can get with Epstein's anomaly or other obstruction like pulmonic stenosis, then our right to left shunting is across the atrial septum, and then this causes right heart enlargement, and the right to left shunting across the atrial, or marked right heart enlargement, and the right to left shunting across the atrial septum is what results in the cyanosis. So the classic lesion here is Epstein's anomaly, and then we have these others, tricuspid atresia with a restrictive atrial septal defect, critical pulmonic stenosis with ASD or PFO, and pulmonary atresia with intact ventricular septum type 2. But Epstein's is the typical lesion. So the plain film appearance of Epstein's decreased pulmonary vascularity, marked enlargement of the heart, especially the right atrium. This particular configuration, this appearance is called what? There's a term for this.
Box-shaped.
On the box-shaped heart, and also wall-to-wall heart. Wall-to-wall heart, going from one end of the chest to the other. Okay, so those findings on the plain film can be associated with Epstein's. And then when we look here, and what's happening is that the tricuspid valve is displaced towards the apex, and the malformation results in obstruction of blood flow through the right heart. So the functional right ventricle here is actually quite small. ARV, that stands for?
Accessory?
No. Atrialized right ventricle. Okay. This part should be the right ventricle, but it functions physiologically like the atrium because the tricuspid valve is displaced. So that's called the atrialized portion of the right ventricle. Notice the right atrium is enlarged here. So you get all of this right heart enlargement, and that's why the right atrium looks enlarged on the plain film, bulging off towards the right. And then if there's usually an ASD or a PFO, results in right to left shunting across the septum, which results in the cyanosis in these patients. Okay, so we have a CT, we have an MR. What is this illustrating? By the way, notice that this chamber is what? Left ventricle, this guy is right ventricle. Why is the right ventricle so small? Look how small that is. Why is the right ventricle so small? So this is tricuspid atresia. Atresia of the tricuspid valve. How do you recognize it on the imaging? Yeah, so there's absence of the tricuspid valve. Where the tricuspid valve, here's the mitral valve. So where the tricuspid valve is supposed to be is replaced with fat. See? Right there. So that is tricuspid atresia. Right? So tricuspid atresia. Now tricuspid atresia can be associated with transposition or not. And it turns out that the form that is not associated with transposition, they tend to have pulmonic stenosis. So that's associated with cyanosis and decreased pulmonary blood flow. So tricuspid atresia can appear in both categories here, of cyanosis with decreased blood flow or cyanosis with increased blood flow, because it can also be associated with transposition. And when it is associated with transposition, the pulmonary artery comes off of the left ventricle, there is no pulmonic stenosis, so these patients will have increased pulmonary blood flow. So you can have tricuspid atresia with increased blood flow and cyanosis. You can have tricuspid atresia with decreased blood flow and cyanosis. Right? So tricuspid atresia with pulmonic stenosis, that makes up about 75% of those cases. That might resemble tetralogy of Fallot. Tricuspid atresia without pulmonic stenosis, you have increased pulmonary blood flow in those cases. So that's an admixture lesion with increased pulmonary blood flow. Okay. And then also with tricuspid atresia, if you have pulmonary stenosis and decreased pulmonary blood flow, the degree of right-sided enlargement might be related to the size of the atrial septal defect. If the atrial septal defect is large, the right atrium does not get that big. But if the atrial septal defect is small and restrictive, then the right atrial septum does get, then the right atrium does get big. And so you have a big right atrium, decreased pulmonary blood flow. That looks like what other lesion that we discussed? It looks like Epstein's, right? So tricuspid atresia has been called the great mimicker because of these, the different malformations that can occur with it can affect the appearance on the plain film. Then there's this curious entity, pulmonary atresia with intact ventricular septum. There's a type 1. So here there's a pulmonary atresia, right, meaning that there's no outflow from the right ventricle into the pulmonary artery. So they have to have a patent ductus arteriosus to survive. So type 1, small right ventricle with a competent tricuspid valve. The competent tricuspid valve results in a small right ventricle. Type 2, these patients have an incompetent tricuspid valve, and so that tricuspid regurgitation then results in enlargement of the right heart. So with type 1, there is no cardiomegaly. With type 2, there is cardiomegaly with right heart enlargement. So that's pulmonary atresia with intact ventricular septum. So with type 1, decreased pulmonary blood flow, heart's not that big. This looks like tetralogy of flow with decreased pulmonary blood flow, and the heart is not that big. With type 2, decreased blood flow cyanosis, the heart is big, especially the right atrium. This looks like Epsteins, right? So that's type 1 and type 2 for pulmonary atresia with intact ventricular septum. Now for this, we have both patients here, pulmonary venous hypertension and failure. So I'm telling you, both patients have pulmonary edema. What's different about the radiograph? What's the obvious difference when you look at these chest radiographs between the two patients? What's the obvious difference?
Heart size.
Yeah, the heart size. So here the heart size is normal, okay? Here the heart is big. So what is the significance of that if we're in this category of failure in pulmonary venous hypertension when we're dealing with the plain film?
It tells you the location
Of the obstruction, right? So if the heart is not big, the obstruction is
proximal to the mitral.
at or proximal to the mitral valve, right? If the heart is big, then there's obstruction distal to the mitral valve, okay? So no cardiomegaly, obstruction at or proximal to the mitral valve, cardiomegaly, obstruction distal to the mitral valve. But it's more than that, because there are other things that can also give you a big heart and failure. So the differential is much larger here when you have cardiomegaly and failure. You can have congenital disease with obstruction distal to the mitral valve. You can have cardiomyopathy or left ventricular failure from any cause, right? So when we're dealing with infants, then the differential is much larger when we have a big heart and pulmonary edema. So this patient has pulmonary edema and cyanosis. What do you think of the heart size? Normal, right? It's not big. So when you see this, what are you supposed to think about as the cause when we have this? They really like this on the boards. They ask a lot of questions about this.
Mitral stenosis.
No. I told you the patient's cyanotic, right? Mitral stenosis is not going to give you cyanosis. So normal heart size, failure, cyanosis.
Vein stenosis?
Not pulmonary vein stenosis, but it is a problem with the pulmonary veins. What do we call it? Total anomalous pulmonary venous return. Type?
Type 2.
No. Type 3. Total anomalous pulmonary venous return below the diaphragm, type 3. All right? So here are your pulmonary veins, total anomalous pulmonary venous return below the diaphragm. What happens is the pulmonary veins get obstructed as they go below the diaphragm. That results in increased pressure in the pulmonary veins and pulmonary edema. So normal heart size with cyanosis and failure, total anomalous pulmonary venous return, type 3. So they ask, this question seems to come up again and again on the exam. Okay. So it can drain to the portal vein, and when it does that, of course, there's obstruction because of the increased vascular resistance going through the liver, and that also contributes then to the pulmonary venous hypertension. So total anomalous pulmonary venous return type 3, when that common pulmonary vein drains below the diaphragm, there's a relative obstruction to the flow through that vessel, results in pulmonary venous hypertension and failure pulmonary edema. Normal heart size, cyanosis, failure, think about this. Total anomalous pulmonary venous return below the diaphragm. All right. Now, if we have pulmonary venous hypertension without cardiomegaly. We can have total numerous pulmonary venous return below the diaphragm. That will give you cyanosis. These other things will not. Cord triatriatum, congenital mitral stenosis, pulmonary vein atresia. So somewhat rare. So this is the one that tends to show up on the exam. Okay. So this patient has pulmonary edema and cyanosis. Right. Infant, big heart. Now here there can be different things that can do it, but what is the congenital cardiac lesion that we are supposed to think about if we have a newborn with a big heart and failure, pulmonary edema and cyanosis?
Tetralogy?
Well, tetralogy does not failure, right? The patient's cyanotic. PDA does not give you cyanosis. All right. This is hypoplastic left heart. Okay. The components of hypoplastic left heart: severe aortic stenosis or aortic atresia. You might have the interruption of the aortic arch, mitral atresia. Essentially, the problem is there's very little blood flow through the left side of the heart in these patients, so they tend to have a small hypoplastic left ventricle. So if they have hypoplastic left heart, why is the heart big?
The right ventricle.
Because it's the right ventricle that's enlarged, okay, with hypoplastic left heart. So what happens is that they will have shunting there through the atrial septum, and the right heart pumps into the pulmonary artery and also winds up pumping into the aorta through a patent ductus arteriosus. So the right heart winds up pumping for both circulations because the left heart is not working well at all. And so the overload on the right heart then results in failure. Okay? So hypoplastic left heart is associated with big heart failure, infant cyanosis. It's the most common cause of cardiac death in the first few weeks of life. So these patients will have a small ascending aorta because embryologically there's very little blood that is going through the left-sided chambers, and so the ascending aorta does not get perfused well, so it doesn't develop properly. All right, so they have a small ascending aorta. Here, when they inject the pulmonary artery, the contrast actually winds up going into the descending aorta because it is going through a patent ductus arteriosus. So the descending aorta here is perfused by a patent ductus arteriosus from the right heart, okay? So that overload then on the right heart and the elevated pressures in the left heart result in failure in these patients. So that's hypoplastic left heart. Now, if you have pulmonary venous hypertension with cardiomegaly, we can have obstruction distal to the mitral valve, cardiomyopathy, left ventricular failure. So any causes of failure can result in a big heart and pulmonary edema, right? So we talked about hypoplastic left heart. Those patients will have cyanosis. But you can have patients without cyanosis with coarctation, severe aortic stenosis, myocarditis, storage diseases, endocardial fibrinostosis, AV fistulas, Al Kappa, right? So all of these can also result in heart failure and pulmonary edema, but they won't have cyanosis. So the differential when you have an infant with failure and pulmonary edema is much larger. Okay? So here's an example with severe coarctation. We have failure here, okay, and a big heart because of severe coarctation. So the left ventricle fails. It dilates and fails with severe coarctation. Now let's talk about the aorta and the pulmonary artery, because this can also be helpful when you're dealing with the plain film. All right. So this patient has cyanosis, and they have a right arch with decreased pulmonary blood flow. So what is the lesion we should be thinking about here? Yeah, so here we think of tetralogy of Fallot. Also, there's an upturned apex, right? So tetralogy of Fallot is the lesion that gives you, of course, there's decreased pulmonary blood flow, okay? But it can be associated with right aortic arch and relatively near normal heart size. So right arch with decreased pulmonary blood flow, we want to think of tetralogy of Fallot. Now, what about this case? Here we have increased pulmonary blood flow, cyanosis, but we also have a right arch. So if you have, look at when you're trying to figure out where the arch is, look at the trachea. So the indentation on the trachea tells you where the arch is. So here the arch is on the right. So if you have a right arch with increased blood flow and cyanosis, what lesion are you supposed to think of here? Truncus arteriosus. So here you consider truncus because truncus also is associated with right aortic arch. Now, when we look at the right aortic arches associated with particular congenital heart diseases, about 35% of cases of truncus will have a right arch, about 20% of tetralogies will have a right arch, and then I've given you these others also, all right? So truncus and tetralogy, both of those are associated with right aortic arch. Nice case of tetralogy here with the boot-shaped heart and the right arch, all right? But if I tell you, if we have 100 kids with congenital heart disease and right arch, because tetralogy is much more common than truncus, then here tetralogy is going to be more common. Okay? So tetralogy is the lesion associated, most frequently associated with right aortic arch. But use the pulmonary circulation, right? If you have increased circulation in right arch, you're going to go with truncus arteriosus, certainly not tetralogy in that case. All right. Distribution of congenital heart disease, I've given you this also some idea of what the most frequent congenital heart diseases are, VSDs, ASDs, so these, and PDAs, so those, of course, are going to be up near the top. All right. So this might also help you in terms of the probability of different congenital heart disease. So let's summarize. We start the discussion of congenital heart disease with the pulmonary circulation if we're dealing with the plain film. If there's increased pulmonary blood flow, you want to know, is the patient cyanotic or not cyanotic? If there is no cyanosis, you're in the category of left to right shunts. ASD, VSD, PDA, those are the most common. If there is cyanosis, you're in the category of admixture lesions, bidirectional shunts without pulmonic stenosis. The big three there, transposition, total anomalous pulmonary venous return, truncus. You want to know these three well. Okay? You can also have tricuspid atresia without pulmonic stenosis. We talked about the T lesions. They should not have pulmonic stenosis. If we have decreased pulmonary blood flow, we will have cyanosis. If there is no cardiomegaly, tetralogy of Fallot or tetralogy-like lesions, so those tend to be lesions with ventricular septal defects and pulmonic stenosis. That's the basic physiology of tetralogy of Fallot. Also, pulmonary atresia type 1 could fall in that category. If you have cardiomegaly with decreased pulmonary blood flow and cyanosis, the classic lesion here, especially with right atrial enlargement, is Epsteins. But we have a couple other things, pulmonary atresia type 2 with attack septum, or tricuspid atresia with pulmonic stenosis. All right. But this is the one that you want to know about, Epsteins. If we have pulmonary venous hypertension, no cardiomegaly, obstruction at or proximal to the mitral valve. Make sure you can recognize total anomalous pulmonary venous return type 3. This gives you failure with normal heart size. The pulmonary vein is draining below the diaphragm. These patients will be cyanotic. The differential is much larger if you have failure in cardiomegaly. You have obstruction distal to the mitral valve. If you have a big heart in an infant and a newborn with cyanosis, think of hypoplastic left heart. But cardiomyopathy from any cause, left ventricular failure from any cause, will give you a big heart and pulmonary edema. Of course, these patients will not be cyanotic. So, pulmonary circulation increased. What question do you ask? Is the patient, so if the patient is not cyanotic, we're in the category of left to right shunts, right? So now you'll look at the heart, chambers. What do you think? Yeah, it looks like maybe there's some right heart enlargement. Do you think the left atrium is big or not? So what do you go on? What's the answer? ASD. There's an atrial septal defect, and here you have your right heart enlargement. Okay. All right. So here, pulmonary circulation increased. I'm telling you, the patient is cyanotic. You're in the category of admixture lesions. The three big ones there. Total anomalous pulmonary venous return. Looking at the plain film, what might you favor? Why are you saying tall anomalous pulmonary return?
It's kind of like a snowman.
Maybe kind of like a snowman? What else could this be over here?
Right aortic arch.
If it's a right arch, what would it be then? What's the answer? Truncus arteriosus, yeah. So here's your VSD, there is your truncus, there's the aorta and the pulmonary artery. Okay. This patient, pulmonary circulation, decreased. Patient is cyanotic. What do you favor here and why? Heart, by the way, yeah, heart size normal or near normal, yes. So here you favor tetralogy, why?
Boot-shaped heart.
Boot-shaped heart
Right-sided aortic arch.
and right-sided aortic arch. The components of tetralogy,
VSD, right ventricular enlargement.
right ventricular hypertrophy, ventricular septal defect,
Outflow tract obstruction.
infundibular obstruction, right? Overriding aorta. What does overriding aorta mean?
Over the VSD.
Yeah, so the aorta overrides the VSD, meaning it can receive blood from both ventricles, right? So that's why you get the right to left shunting. It's going into the aorta from the right ventricle, okay? Okay, this guy, pulmonary circulation, little puff. Let's say it's decreased. Okay, good. So the patient is cyanotic. What do we think of the heart size here? Big. Right atrium is enlarged. Right? So what are you thinking about here? Yeah, it could be Epsteins, right? Is there anything else it could be? Does that look like what did we say about hypoplastic left heart? What do you have to have there? Tut, 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 tut. Failure, right? You want failure there, okay? Right. So here, let's see what happens. So we do an angiogram here. Inject the right ventricle. This guy is supposed to be what? It's supposed to go out into the pulmonary artery, but it doesn't. It doesn't go anywhere. It's pulmonary atresia. Instead, it goes backwards into the right atrium. Then from there, it goes across the atrioseptal defect into the left atrium. Right? So this is pulmonary atresia with intact ventricular septum, type 2. Right? Pulmonary atresia with intact ventricular septum, type 2. Okay? See how easy this is? All right. All right, so that's it for today. So next left to right shunts next week.